Okay, Sabine, is now over to you.
Good afternoon, everyone, and thank you for joining my presentation. Just a little bit about myself. My name is Sabine Whittington, and I work for NELFT as an ESP in the Spinal and Musculoskeletal Assessment Service, and I'm based at Howard Wood Polyclinic. And today I'm going to present on dizziness and vertigo, and I will try to cover the learning objectives that you kindly sent to Paula for today's session. It's quite a lot to cover, and I hope we get through it, and hopefully there will be a little bit of time for questions at the end. Okay, so this is what we're going to touch on today, a little bit around anatomy and physiology of the vestibular system, talk about causes of dizziness and vertigo and potential differential diagnosis. I'm going to talk a little bit more in depth around BPPV, or benign paroxysmal positional vertigo. And then we're going to look at assessment and treatment principles. And at the end, I have a few links for you that you can look up and contact details. So this is the vestibular system. It's just a few millimeters big, and we have one in either ear. So this system contains of the cochlea, which is the auditory side. So we're not going too much into that today. What we are concerned about is the this side of the vestibular system. So we've got this little sort of bulky system here in the middle, and attached to that we have three semicircular canals, and they're all aligned in a different way, and they're all filled with fluid. And as we move about, this canals is in motion, and in these canals, in each of these canals, there are little sensory organs. They are called ampullae, and they're like little hair cells. And through the motion of the fluid in these canals, these hair cells are bent left, right, up, down, and that impulse is sent to the brain via the vestibular nerve. And the brain then decides where we are in space and if it's happy with that. So this is, in a nutshell, how this works. This little system, or actually no, here in that little system in the middle, there are hair cells as well. These hair cells, they're embedded in a jelly-like layer, if you like. And in this jelly-like layer, we have what is called otoconia, these like ear rocks, particles. And they become really important later when we talk about BPPV. So it's just that you know that they are naturally in this central part of the vestibular system. They have a purpose there. They make this jelly-like layer heavier, so the hair cells in that area, which are picking up accelerating motion, it just makes this area heavier so it can pick up that motion easier. While these canals on the side, that pick up other movements like bending movements, side-to-side movements. So every one of these canals picks up a different type of motion. And this is where this little system is located. So it's quite far in the inner ear. And like I said, we have one of those in each ear. The next important thing to talk about is the vestibular ocular reflex, which this reflex is responsible for keeping the eyeball steady when our body is in motion. So, for example, if you focus on something on the screen now or somewhere else, focus on something and turn your head over to the left, you will find that your eyes automatically go the opposite way. So they go to the right, so you can keep focusing on whatever you're looking at. If you turn your head to the left, to the right, your eyes automatically turn to the left. If you lift your head, your eyes go down. If you bend your head, your eyes go up. So this is this reflex, always going opposite to your head's motion to be able to keep the eyes steady. And this is important for focus. So for example, if you think about, let's say you walk down an aisle in the supermarket and you see an item at the end of the supermarket that you want to get, and you have to move left and right around people, but you need to keep looking at that particular object. It's that reflex that allows you to keep your eyes steady on that object while you move around, while you move your head, while you move your body. And this reflex needs to be extremely fast. And if it isn't, this is often a problem with people who suffer from unsteadiness, lightheadedness, because this reflex has become slow or delayed, and the eyes don't catch up quite with the motion that we're going through. So we come to that back a little bit later and discuss how we can assess this and how we can treat this, but this is something else to remember. So here we've got various courses for dizziness and vertigo. On the left-hand side is probably what we see sort of mostly in our clinics. One of the most common courses is BPPV, which we're going to talk a bit more in detail in a minute. Then we've got labyrinthitis, vestibular neuritis, which is basically a infection of the inner ear or the vestibular nerve. Then we've got Meniere's disease, which is an autoimmune problem, migraine that can be associated with dizziness. There can be central causes like stroke, MS, blood pressure problems. So low blood pressure obviously can make people dizzy, so can high blood pressure. The neck can cause a sensation of lightheadedness or unsteadiness, but not so much vertigo, not so much spinning sensation. The C2-3 segment is one of those that can cause a little bit of that unsteadiness, not so much associated with spinning. Then other causes are an uncompensated vestibular dysfunction. So that's what I mentioned earlier on. If someone has, for example, a delayed vestibular ocular reflex, or they've had an acute labyrinthitis and they never really recovered fully from it, and they end up with the sensation of lightheadedness, ongoing sensation of lightheadedness and dizziness. Then we have obviously vascular compromise, like the vertebral artery or the carotid arteries. So that's our red flags. On the other side, depending obviously on where you work, this is something that you might come across as well, but obviously that will need some very different attention to what we are going to talk about today. So how do I know what's what? The BPPV is a positional related dizziness or vertigo, and is one of the most acute and very violent brief episodes of spinning. So BPPV causes spinning, and I will come to that a little bit more in detail in a minute. It's very much underdiagnosed. So I would really, as we go through the assessment, I would really encourage you to check your patients for that. Migraines present a little bit differently. They're usually, or dizziness related to migraine usually occurs with some sort of associated head pain. They're more spontaneous, so they're not so much induced by a certain position. They can come on any time. You sit still, you lie still, you're driving, and they usually last quite a bit longer, minutes up to hours. Where the BPPV, like I said, very brief episodes and potentially just under a minute, and the symptoms will subside again. Meniere's, an autoimmune disease, again, more spontaneous onset, can come on any time, not particularly relating to any movements, although it can. It will last a lot longer, so the attacks usually last for hours, and usually associated with like a pressure feeling in the ear, hearing loss, tinnitus. And then we have labyrinthitis, again, a less violent sensation of dizziness or vertigo, and the movement itself brings on the symptoms, and that can last up to weeks until the infection or inflammation has calmed down, and that usually responds to medication. Then obviously, if we are concerned about vascular compromise, we need to think about our 5Ds, and you would expect this to occur with sustained neck positions, and not necessarily related to moving from one position to the other. The vestibular neuritis, pretty much like labyrinthitis, not so violent, not so much spinning, and again, response to medication, and it can last for quite a few weeks, and then it will get better. Then we have an acoustic neuroma. You might, with that one, you might not get that spinning, you might just get mild vertigo, mild dizziness, and you potentially have other cranial nerve signs as well. Or for central disorders, you would expect other neurological signs and symptoms, imbalance, these type of things. So this is just a little overview how to potentially know what you're looking at when you're assessing your patient. So let's have a little look more in particular at benign paroxysmal positional vertigo, or BPPV. So benign obviously means it's not dangerous, it's not cancer. Paroxysmal, it comes on in sudden attacks. Positional, it's related to certain positions, so certain positions you get yourself into, and then the vertigo is the spinning. So back to our little diagram. So we have these three canals. Actually, I might go back to the other one because that shows that potentially better. So I mentioned earlier on that we have these otoconia, these ear rocks, located in that little vestibule system in the middle here. For unknown reason, or for the majority of people, there is no actual cause. These little otoconia or ear rocks, they become loose and they start floating about in these canals. Yeah, so these fluid-filled canals, all of a sudden you've got some particles swimming around in there. This is what the BPPV is. This is very, very common in the elderly population. So there is potentially a degenerative process, although I have seen many younger patients as well, without any trauma, without any particular mechanism of injury or trauma to the head, and they develop these symptoms. But it is more prominent in the elderly population, so potentially a degenerative process. It can occur after someone has a big bang on the head. Like I saw a lady a little while ago, a younger lady actually. She was just in her early 20s, and she walked into a lamppost while she was texting on her phone, big bang on the head, and she developed BPPV afterwards. Or you might find people develop this after they've had a whiplash, or even after they've been on bed rest for a while. So there's no clear cause for BPPV. But what it basically is, these otoconia become dislodged and they float around in these canals. And what happens then, this fluid, like we said earlier on, the fluid in these canals, they, as we move about, they bend this little sensory organ, and that then stimulates the vestibular nerve for sending this information to the brain. So what happens with BPPV, these particles or otoconia, they usually end up sitting in this canal here, purely because of its location, because it's the most dependent canal of the three that we have. So they usually sit around here at the bottom. So the person starts moving and this fluid starts moving, and then these particles start moving, stimulating the ampullae in here. So that person stops moving. However, because of these particles in here, the fluid in the canal actually continues to move, and it continues to stimulate these little hair cells, which continues to send information to the brain that the person is moving when it's not. And this confusing information then causes that vertigo. So if you think about it, just to understand that a little bit better, if you think about a glass of water, if you have a little bit of sand sort of sitting at the bottom of the glass, if you start turning that glass, eventually that sand that's sitting at the bottom of the glass will start moving as well. And if you then stop moving the glass, that sand will still move in your glass of water for a while before it settles again. And this is exactly the same what happens here. So these otoconia, they keep moving when the person has stopped moving, and keep moving that fluid around, which keeps stimulating that sensory organ, which keeps sending that false information to the brain. So it's basically disturbing the normal information process to the brain. Just going to go back to my other picture now. Okay. So there are two theories here. So one is called canalithysis. This is what I've just explained, where the otoconia sort of floats around in these canals. The other theory is called cupulolithysis. That is extremely rare, but what happens there, rather than floating free in the canals, the otoconia actually is attached to that little hair cell, to these little hair cells, and it's stuck to the hair cells, and it bends the hair cells permanently while that particular person is in a stimulated or an aggravating position. And while the person's in that position, because the hair cells are bent, they will send that false information to the brain. So in that case, the vertigo does not stop until the patient or the person comes out of the aggravating position. With the canalithysis, where the otoconia are free floating, as soon as the otoconia settle, the symptoms will stop. Yeah, so that's the difference. The canalithysis is very, very common. The cupulolithysis is very rare. I think I've seen 2 patients as long as I've been seeing dizzy patients with the cupulolithysis, so it's extremely rare. So we won't go too much into detail here. So characteristics of BPPV. So there is a sudden onset. It's associated with a severe spinning. So it's either that the patient feels the room is spinning or they're spinning themselves. It's often associated with nausea or vomiting. So if you are going to treat these patients, always be prepared, have a sick ball, because they do get sick. The vertigo lasts about 60 seconds, not much longer. So this is the time it takes for this otoconia to settle down in the fluid again, and then to stop stimulating the hair cells. And for BPPV, the most aggravating position, or what patients will report, are looking up, bending down, lying flat, and turning over in bed. They may tell you other things as well, but they are the very commonly reported position where people get their vertigo with BPPV. In the textbook, it says there has to be a nystagmus present. Has to be present. I'll talk about nystagmus in a minute. You may find, so nystagmus is like an involuntary movement of the eyes. Not if someone's had these symptoms for a long time, you may not actually see that nystagmus, or the patient has learned to be able to really steady their eyeballs, so you actually don't see this eye movement. But it is one of the classical signs for BPPV, but it depends on how long the patient had it and how well they're compensating for this, if you see it or not. So in 90% of the cases, the posterior canal, which in the picture earlier on, the lowermost canal, so 90% of the cases is that canal that is affected due to its position. So it's the most dependent canal. And if we're upright, obviously gravity would pull the otoconia into that area. In very few cases is the lateral canal affected. That often happens if you treat BPPV with the Epley maneuver, and you can potentially shift some of that, some of the otoconia into this lateral canal. And very, very rarely the anterior canal is affected. That's the one that was on the top. And I've just seen one patient in all the time I have been seeing dizzy patients. I've just had one patient where the anterior canal was affected, but due to its position, if someone's upright, again, gravity would just pull the otoconia out of this canal, and it is with that self-limiting. And the cupulolithysis, which I mentioned before, is very rare. Bit of a different approach to treatment, but like I said, it's extremely rare. if you have a patient with BPPV, you're very likely that you're going to look at the posterior canal being affected. So when a patient comes to you with dizziness, what's really important is that you take a thorough subjective history, like it is important with anything else we do. Sometimes people come in and they had these symptoms for 10 years or even 20 years, so it's a long time ago. So it's really important to drill down, what was it like at the beginning? And that's sometimes difficult if it's been a long time, but it does help with diagnosing. If someone had BPPV for like years, which is again very common, their symptoms change just because patients, they adapt, they move differently, they don't move so fast, they don't bend their heads. So they may not get the severe spinning anymore because they have adapted, but they end up with this constant lightheadedness or dizzy sensation or even unbalanced feeling. So it's very important when you take your initial assessment that you go back to how did it start, what were the initial symptoms, was there an injury, was it a gradual onset, was it sudden, how has it been presenting over the years, does it come in episodes, is it there all the time? You want to ask around the current symptoms, is it a spinning sensation or is it more a sensation of lightheadedness or loss of balance? Is there nausea and vomiting associated? Do they get headaches? Do they have anxiety or panic around it? Any visual problems? Is there hearing loss, a tinnitus, that pressure in the ear, what we mentioned earlier on about potential Meniere's? You want to know what's aggravating, what's easing the symptoms. Is positions that I mentioned earlier on, is it when they're bending down? Is it when they're looking up? Is it when they roll over in bed? Is it more to the right? Is it more to the left? So drilling down on what positions or what's aggravating their symptoms, and also what makes it easier, which is usually moving slower or not getting into the aggravating position. Have they had any investigations? What is their past medical history? Have they had any trauma to the neck or the head in the past? Are they on medication? What's the response to the medication? Have there been any falls? Have they had any previous treatment? What was the response to the treatment? So this is really important to drill down on all these questions, checking our red flags, to get to a diagnosis. So if you suspect BPPV because it is a spinning, it comes on with certain positions, it doesn't last very long, then there are tests we can do to provoke. It is provocative, so that's a bit problematic, but there are certain tests we can do to provoke the symptoms and the nystagmus. And if you can see the nystagmus, you can actually diagnose what part of the inner ear or what part of the vestibular system is affected. So that's your gold standard, but it's not always easy to see because the patient might not want to open their eyes because the symptoms are so strong, or as I mentioned before, they may have learned to really steady or stabilize their eyes, so you might not even see that nystagmus. So as I said before, a nystagmus is an involuntary eye movement which can have lots and lots of different causes, but we stick with the vestibular cause today. So obviously there can be neurological problems, there can be congenital problems, but so there is always a faster and a slower component to nystagmus. It can go all sorts of directions. It can go side to side, up and down, it can turn, and the character of the nystagmus will, as I said, will help you to diagnose, and the direction and the duration will help you to diagnose what problem you're looking at. So in BPPV, if you have a posterior canal problem, which, like I said earlier on, is the most commonly affected area in the vestibular system, what you're going to see nystagmus-wise is a torsional nystagmus. So the eyeballs basically twist in the socket. The nystagmus is going to be geotropic, which basically just means that the fast beat is towards the affected side. Yeah, so it's twisting in the socket and the fast component is towards the affected side. With the posterior canal, you have also an upbeating component. So that means you can see a bit of a beating against the upper eyelid. And it fatigues, I would say, within 60 seconds, if not quicker. If it's the anterior canal, which is very rare, you have, again, the torsional component. You've got the geotropic component, but you have a downbeating component as well. So instead of beating towards the upper eyelid, it beats towards the bottom eyelid, and it fatigues in the same time frame than the posterior canal. If it's the horizontal canal, the one that's on the side, you have a nystagmus that's purely horizontal, so you don't have the torsional component, and it also beats to the affected side, and it fatigues just like the ones before. With the cupular lithiasis, again, very, very rare, it doesn't fatigue, like I said earlier on, until you move that patient out of the aggravating position, and the fast beat is actually away from the affected side. And then with central problems, you get all sorts of different types. I'll show you a couple of videos in a minute, but you get all sorts of different types of nystagmuses. That may sound all a little bit confusing, but if you just remember the posterior canal, because this is what you're mainly going to see with BPPV. So the one on the top, if you see a twisting component, a torsional component, it beats to the affected side, it beats towards the upper lid, and it will fatigue within a minute. So I'm going to show you a few videos now. Are you able to see this YouTube video? Could someone just let me know?
Yes,
Yeah,
yes,
okay.
we can see, but you might need to make it a bit bigger.
Yeah,
Sabine.
I will do. Yeah, we'll do. Okay. So this is a very good video because this patient has a little bit of a line in their pupil. So if you look at this line, you can, so this is going to be a nystagmus of a posterior canal BPPV. So if you look at the eyeball and that little line that they have in the pupil, you can really see that torsional component. It doesn't last very long, but you can see the torsional component. It's beating up towards the top lip, and it will have a fast and slow component. So I'm just going to turn this on now. So can you see how it beats to the upper lid? And then if you look at that little line, you can see that the eyeball is actually twisting. I'm going to take it back a little bit so you can see that again. And if you imagine that's happening, that's not going to be comfortable and can cause a lot of dizziness. And you can see it fatigues already. So this is the typical posterior canal BPPV. Oops. So it's beating to the top lid, and you have that torsional component and the fast component towards the right side. So that is the posterior canal. I'll show you a horizontal canal now as well. So here we have purely the side-to-side movement. So, hold on. What that is. Oh, hold on. Not quite sure where that comes from. I apologize. I can't see where this is coming from.
You might have multiple.
Oh, here, I've got it.
That's good.
Okay, sorry, I was going to turn it. I apologize. So back to sharing. Ola, I can't see the sharing anymore.
Should be able to share. Try sharing again.
I can't see the sharing button anymore.
You have a full screen.
Let me have a look.
So you might need to either maximize your screen.
Just top the click on the black bit at the top of the screen, just above all the pictures, Sabine, it will come back.
I can't seem to get back to.
Okay. Okay. So you're going back to the presentation itself, or?
I'm in the presentation. I can see the presentation, but I can't. The share button doesn't come up.
Okay. What slide number are you on your slide?
Number 15.
15. Okay. Give me 2 minutes. Okay.
I can't actually see the actual presentation anymore. Oh, I do apologize.
It's okay. I'm sharing the presentation, so so you don't have to worry. Okay, so this is slide 15. So I'm going to mute myself so you can start. Can you see my screen, Sabine?
No, I can't see. I can hear you, but everything's
Okay. Oh,
okay.
dear.
Well, I can just continue. So that video was the most important one that I wanted to show anyway. So is that torsional nystagmus that you are going to see with the posterior canal BPPV. The other one that I was going to show there, things that you're unlikely to see unless you work in neurology. So there were some central causes for nystagmus, but the one I just showed you is the one that you want to look out for. So it's that torsional component, that fast beat to the affected side with that little bit of a beating towards the upper lid. Paula, if you could go to the next slide.
Yeah, I'm on the next slide.
Yeah. So Hopek-Dix. Yeah.
Yeah.
Okay. Fine. So the Hopek-Dix test is the test that we can test for BPPV for. It is a provocative test, so you really have to take informed consent from your patient before. And what I tend to do, I'll explain to them why I'm doing this. I demonstrate it, and the patient can then make a decision if they want to go through that test. You basically have to rapidly move the patient from a sitting position with the head turned 45 degrees to the side that you want to test, and then you bring them quite quickly to a lying position with the head tipped below the horizontal. And this tests the anterior and posterior canal. So I have Paula, if you go to the next slide. Are we on the next slide?
Yes, I am.
Yeah. So this is a picture. What I would recommend if you want to perform these tests, I would have a look at YouTube. There are plenty of YouTube videos where you can see the technique. What basically happens, you move as you can see in the picture here, you move the otoconia that's resting, or these particles that are resting in the posterior canal, you move them from the most dependent position, which is the bottom part, up to the top position by putting the patient's head over the edge of the bed, and you will produce the patient's symptoms and potentially that nystagmus. In this picture, or most people, they stand sideways to the patient. I prefer standing behind the patient so I can sit down and support the patient's head in my lap. This is a bit, because it is provocative and the symptoms can be very strong. Make sure you have practiced that before. And obviously there are no red flags. The patient is able to do that. And practice it so you get good hand position. Practice it on someone who hasn't got symptoms, obviously. And like I said, on YouTube, there are plenty of videos where you can watch the technique for this test. If you go to the next slide, Paula, please. Are we on the next slide?
Yes, we are.
Okay, so the Hopek-Dix is positive if you get a little bit of a latent period before the onset of the spinning on the nystagmus. The latent period is because if you think back of that glass of water with a sand in it, it takes a moment when you're moving for this sand to move, and this is the same. So the otoconia take a moment to get into motion, and that's why there's usually a bit of a latent period. Then we have the nystagmus, like we watched a minute ago, the torsional nystagmus that beats towards the affected side, and if the posterior canal is affected. And the nystagmus and the vertigo usually subside within under a minute. It's usually 20-30 seconds, but it is quite strong, and some patients panic. So be prepared. It might be useful to have a relative in the room who can hold their hand, or have a colleague in. The nystagmus and the symptoms can reverse on sitting up. So you can get symptoms again, but the nystagmus will reverse, and it fatigues on repetition. So if you repeat the test a few times, you will get less of a response. Next slide, please, Paula. Thank you. So treatments for BPPV. For the posterior canal, the Epler maneuver, you might have heard of that. It's a very, very effective maneuver to reposition these otoconia. 75 to 80% of people get better with one treatment. If people can't tolerate this, then you can give us some exercises, the Bandarov exercises. For the horizontal canal, it's a slightly different maneuver, but it's all around repositioning these little otoconia or earwax around the semicircular canal back into the vestibule where they belong. Next slide, please, Paula. So this is the Epler maneuver. So here we're treating the right side. So the patient sits, head is turned to the right side. You come down, have the head in slight extension, wait in that position until the symptoms subside. Then you turn the head to the left, wait until the symptoms subside. The patient rolls onto their left side. Again, wait until symptoms subside. This is the position where people usually get sick, if they get sick, and then you sit them up again. Next slide, Paula, please. So here it just shows you how the otoconia moves through the semicircular canal. So if you go on the next slide, Paula, please. So that's just the next step. The next slide. Patient rolls onto the side, and then you sit up. So next slide, the patient is sitting now. And if you look at that little picture of the vestibular system, the otoconia is now back in the vestibule where it doesn't affect that fluid movement in the semicircular canal. Next slide, please.
Yeah, were there, is it the red flags?
Hold on, no, I'm not. No, I'm back. The first slide after the pictures, post-Epler maneuver, please.
Okay, yeah, we're there. Yep.
So if you do this maneuver, keep your patient in the department for another 15-20 minutes just to make sure they're okay, because they can feel quite lightheaded afterwards. It is not uncommon to get some short bursts of vertigo after that treatment for a couple of days, so make your patients aware. Some research says to sleep on a couple of pillows, about 45 degrees angle for a night, just to make sure the otoconia stay where you put them. And then I get my patients for a few days to just avoid provocative positions, just to keep the otoconia where you put it. And then after a few days or after a week, I'll get them to try out all the positions that usually produce the vertigo. And if you had a good technique, symptoms will be gone. And then obviously you follow your patient up. You can phone them or bring them back in. You can repeat the Holbein Dix when they come in if you feel you need to. If the symptoms are gone, I tend to not to retest as long as the patient is happy and has got no symptoms anymore. The maneuver can be repeated if you, for whatever reason, maybe technique wasn't quite right, or the patient was resisting, wasn't really getting in the gravity-dependent position. Might have a little bit of that otoconia left. The symptoms might be a lot better, but still have a little bit of symptoms, and you can repeat the maneuver to get rid of the rest of the otoconia. Next slide, please, Paula. So complications of the Epley maneuver, obviously, like I said, nausea or vomiting, have the sick ball there. I had to clean the floor a few times, so you live and learn. Obviously, failure due to poor technique. That's why I said make sure you practice these maneuvers. You have good hand technique. You know what you're doing. Potentially a worsening of the vertigo after, but this is very rare. Like I said earlier, potentially the otoconia slips into the lateral canal, but then you have to treat this. It's not difficult. There's a maneuver for that as well. And for some people, you reposition the otoconia and they just keep coming out. So they get better and then it comes back. But again, there are things we can do to teach them how to get into these repositioning maneuvers themselves. Next slide, please, Paula. Red flags, obviously, if you have any concerns around, like I said earlier on, vascular compromise, you wouldn't obviously do any of these tests or any of these treatments. If you think is something more central or it doesn't fit with the pattern, they have severe headaches, if they have a massive cardiac history, just be a little bit mindful, discuss with the GP or the cardiologist if they are safe to go through these motions, because they are rapid and obviously cause quite intense symptoms. Also keep in mind the neck, you need to have a little bit of range of movement in the neck. So if someone's neck is really, really stiff and painful, you might not be able to do that. Also think about if they had neck trauma, is there potential upper cervical instability, so you wouldn't obviously do the test then or these treatments either. So just think around that one. It needs to be safe to do that, and the patient obviously get your informed consent. And always have a responsible adult accompany the patient home afterwards. So I never let them drive home or go on public transport on their own. So that's really important. Okay, next slide, Paula, please. So this is another way of treating BPPV. If a patient cannot tolerate the maneuver, if they can't, if they're scared, if they've got too much anxiety, this is a way where the patient at home can perform a series of movements, and that is very effective as well. But these movements have to be, or these exercises have to be done for about a couple of weeks before they actually show some improvement. While the Epley maneuver, you get immediate results, which is really fantastic, especially if someone's had symptoms for like 10 years plus. So it's quite good. But with these exercises, they're effective as well for patients where the maneuver is not suitable. Next slide, please. This is what the Bandara exercises look like. So the patient sits and just rapidly moves from side to side. This is particularly good if you can't figure out which side is affected. So I think I forgot to mention earlier on with the Hopike-Dix test, you test both sides, and then obviously the side that is symptomatic is the side that you treat. Your nystagmus, if you can see it, like I said, bouncing towards the affected side anyway. So this is good if you can't figure out which side is affected, or if the patient is a bit anxious around having that maneuver performed. Next slide, please. So this is the lateral canal. So there is a different test because this canal is aligned slightly differently. So because it's aligned in a horizontal way, you have your patient lying on the bed with the head about 30 degrees in flexion. So just have a pillow or two under the patient's head, and then you turn the patient's head quickly to the right or left, whichever side you want to start. Check if you produce symptoms, if there is a nystagmus, let it settle, come back to the center, and then you quickly turn them to the other side. And again, it's the same then with the posterior canal, the side where you reproduce symptoms, where the nystagmus occurs and it beaks towards the affected side. This is the side you need to treat, and I'll show you how to treat that. Next slide, please. This is the treatment for the lateral canal. This is called lock roll or barbecue technique. You basically turn the patient 360 degrees, like they're on a hog roast, if you like, and with that you move the otoconia around the canal back into the vestibule. So you start with the affected side down, let them roll onto their back, onto the good side, and then you get them to come up. So their head always needs to be horizontal in relation to the ground to allow gravity to pull the otoconia around. Again, very effective, but again, the lateral canal is not very often affected. Next slide, please. So when you have a patient come to the clinic with symptoms of dizziness, as I said earlier on, the sort of in-depth subjective history is really, really important, because that will give you a bit of an idea of what's going on. Is it potentially BPPV? Like I said earlier on, BPPV is very much underdiagnosed, especially in the elderly population, and patients are put on medication, or they become really fearful, or they fall. It's very, very underdiagnosed. So it's really good to check for that with all your dizzy patients if it's safe to do so. So a good thorough subjective history, look at the onset, what are their current symptoms, what are their X and E's, what's in their past medical history, what's their response to medication, and red flags, everything that I mentioned earlier on. So then to do a basic vestibular assessment, or basic assessment for dizziness, what you need to be doing, you need to look at the positional test, what we just spoke about, but before, you should also look at the ocular assessment. That means have a look at the patient. Is there a spontaneous nystagmus? So are the eyeballs bouncing around without even applying any motion? If that's the case, that's not vestibular system. That's something central and not for me to treat. Obviously, if you work in neuro, that's a different case, but the treatments we just discussed will not work for that. Then have a look. If there's no spontaneous nystagmus, get the patient to focus on something. That could be a pen that you hold up, or a little bit of blue tack on the wall, whatever it is. See if they focus on something, if that produces a nystagmus, or if it produces any of their symptoms. If they get a nystagmus with the head still, they get a nystagmus just by focusing on something, again, that's more a neurological cause, not so much the vestibular system. So I don't treat these types of dizziness. Then you look at ocular range, like we look at range in any other body part. So you look at how far these eyes are actually moving. You keep the patient's head nice and still. And then I tend to use a pen, and I ask the patient, I move the pen left and right and up and down, and I ask the patient to follow with their eyes. So the head is nice and still. You might get the patient to hold the head by the chin, or you hold it yourself. Head is nice and still, and you just check if they can follow with their eyes and see if that induces any symptoms. They get lightheaded, how far can they actually go? And that is really nice. You can retrain that really nicely. That's something you look at. And then you look at the vestibular ocular reflex, what I mentioned earlier on. So is the patient able to keep their eyes steady on an object while the head is moving? And I do this actively and passively. So I get them to focus on, again, you hold a pen up, or you get them to look at something on the wall, and let them move their head left and right and see if they can keep their eyes steady on that object or not, and if it's provoking any symptoms. If someone has BPPV, that will be positive anyway, because you're moving your head. Then I look at what is called the head thrust. This is more like a surprise maneuver. So again, the patient looks at an object, keeps their focus on an object. I usually sit quite close to the patient for that one, and I get the patient to look at my nose, and then I have my hands on the side of the patient's head and move the head left and right, and then without any, so I move the head then really quickly either to the left or the right without telling the patient before, and I see if they can keep their focus on my nose or whatever you get them to focus on. So it's a bit like a surprise effect, and you just see if they're able to keep that gaze steady while you move the head quickly. So this is a basic ocular assessment which we should be doing with every dizzy patient that comes to the door. So look, is there spontaneous nystagmus? Is there a gaze-evoked nystagmus? Look at ocular range and at the vestibular ocular reflex, then look at your positional tests, the Dix-Hall-Pike, the head roll test. If they can't get in any of these positions for whatever reason, back pain, neck pain, I just basically get the patients to get into what they tell me if they're provoking position. So if they say, if I roll over and back to my right side, I get the symptoms, I just let them do that. And then I check, is there nystagmus? And they obviously tell me if they get their symptoms. So you can use symptom provoking positions as well to test for. And then generally, we also need to look at balance, strength, gait. So I'm not going to go into depth too much here, but this is obviously something if someone had problems with dizziness or lightheadedness or vertigo for a long time, they then don't challenge themselves naturally. So they usually have deteriorated in their strength and in their ability to balance. So that's something that you need to check as well. And then obviously rehab. Next slide, please. So treatment. If through your assessment, if you find BPPV is present, you need to treat this first, just because if you try to correct a vestibular ocular reflex or any balance or strength, the patients will not get better, because every time they move, these otoconia float in their canals and they get disease. So if it is present, you need to address this first through either the repositioning maneuvers or through the exercises I pointed out first. And then you can go on to improve their vestibular function by improving their ability to focus, by improving their ability to focus on something while they move their head, retraining that vestibular ocular reflex. So there are lots of exercises there, the gaze stabilization exercises for the focus, the Coulthard-Cooksey exercises. They are more around the ocular side and head movements and whole body movements. You can use all this. You start in a fairly supported position, in a sitting position, then when they get better, you move them onto standing, into motion, into function. And if someone gets really, really good, it might be even worth to get them to do some sport like table tennis, for example, where you have motion, you have this eye-ball coordination, eye-hand coordination, the eyes need to focus. Pardon me. So this is how you retrain the vestibular hyperfunction. And then obviously, like I said, strength, balance, and gait retraining and education, like we do with anything else. The more the patient knows about their dizziness, the less fearful they become. If they know it is these earwax and we can replace them, they're not quite so fearful anymore. So good education, explaining to them, showing them the vestibular system and what happens can be very useful. Next slide, please. Oh, here we go. So thank you for listening. I have a few pieces at the back here. So this is my email address if anyone has any questions. I'm based at Howard Wood Polyclinic. I myself or our service accepts referral from the Havering GPs only. But I have on the next slide, please, I've got a few links where you can look at effectiveness of the maneuvers that I just mentioned, and links to all the exercises, the Coulthard-Cooksey exercise, gaze exercises, the home exercises for BPPV, and the Epley maneuver. And next slide, I think that's it. Yes. Right, okay, I've lost, I don't know why, but I can't see the presentation anywhere anymore. So if someone wants to unmute and
I've stopped sharing, and I was just going to say this would be a good opportunity for people to unmute themselves to ask questions. I think there was one question while we were going through the session. Someone asked, I wasn't too sure if you saw that, Sabine.
Oh, I'm back. I just found it. Let me just go in the chat. Okay, so let me just scroll back.
Yeah, that was from Priya. Priya at 3:30.
Yeah. Once you provoke the symptoms, can the otoconia go back to the same position? Yeah, so if you just, let's say, if you just do the Hopite-Dix test, you move the otoconia, and then when they get up, it moves back to the most dependent part. I have had patients, though, where just with the first position of the, which the Hopite-Dix is basically the first position for the treatment as well, we had so much momentum that the otoconia actually went all the way around, and there were, they didn't have any symptoms afterwards anymore. So, but that's rare. So usually you have to go through all the different positions using gravity to get the otoconia back into the vestibule. But yes, they can come out again. Like I said, there is no actual, we don't know exactly what causes BPPV, but yes, they can come out again and end up in the same position again. But for those patients, it's worth teaching them to go into these repositioning maneuvers themselves. Does that answer your question, Priya?
Yes, Sabine. I've just asked. Yes, I've just asked another question followed by that. How do we know, obviously, if the otoconia is back? Is it purely based on the clinical symptoms? And approximately how many sessions, does it?
So, as I said earlier on, if you do the Eppler maneuver, really good technique, 70 to 80% of patients completely symptom-free after one maneuver, and the maneuver takes about 5 minutes. Yeah, so this is a real beauty. If you get the technique right, if you get the patient in the right position with in like gravity dependent, so the otoconia can actually move around the canal. It's very effective, one maneuver. You can retest. Yeah, so I tend to, if the patient comes back and said my symptoms are gone, I can roll on the left, I can look up, all their provoking positions or movements are symptom-free, then I'm not going to test again, and that's your proof that your maneuver was successful. Is that okay, Priya?
Yes. Sorry, another question for it. So
Yep.
by doing the test again, can you just provoke the symptoms even if it is settled? Is that right?
Sorry, could you say that again? I didn't catch that.
By doing the test again, you can provoke the symptoms anyway in case if the patient is better.
Yeah, so if the patient is better, that's why I put a question mark in the presentation. Do we need to repeat the test? You can if you want to, but it is quite a rapid movement, and potentially, yeah, it could potentially dislodge the otoconia again. Yeah, so you don't have to retest. If the patient tells you, you know what, I can bend down now and I can look up and I can roll over in bed, you can just literally get them into their usually provoking positions, and they show you, I can do all this now. You can retest, but yeah, there is potentially a risk that you dislodge the otoconia again.
Thank you, Sabine.
I'll just look at the next question. Can we make a referral to you directly? Like I said, we accept referrals from the Havering GPs to the spinal assessment service here. So yeah, so if your patient is a Havering patient, yeah, you can refer to us directly. You might want to ask the GP just to say for attention of Sabine, then for treatment of dizziness. So then it comes directly to me.
Sorry, do we have to ask the GP? We have to request the GP referral to you.
Yeah,
we
so
can't make a referral from ourselves in acute care.
Where is that a Havering service?
So I'm in Queen's Hospital in the acute trust.
Okay, so that's BHR, isn't it?
Yes.
Jade, can I just jump in? Sorry, you might find that in BHR you've got Judith Croxton-Stroud. I hope I've put that the right way around. Who's in the neurophysio team who treats dizzy patients as well. So you might be able to refer directly to Judith.
Okay, thank you.
Pathway.
Thanks.
Okay.
There's another question from There's a question from Amy.
Amy, the information you shared about patient lying at 45 degrees. Amy, in the links that I put on the slide, this explains a little bit more about the follow-up procedure. I personally, in my experience, it doesn't really matter if patients do that or not. If they're unable to lie 45 degrees, they still get better. Yeah, but you can read up in the links that I put at the back of the slides. I have, if you guys are interested, I have a question guide, like a subjective question guide and objective test guide that I can sent to BOLA. So it gives you sort of a summary of what to ask and what tests to do. If you would like to have that, I can send that to BOLA.
Samantha, what would be, I don't know if it would be useful if you can let us have Judy's email address. So for those who are in BHRUT that might not know who Judy is, at least they have an email contact for her. So if they want to speak to their colleagues, they know how to do that. Sorry. I think you're muted. You're muted.
I do apologise. I've linked the button on my headset. That's what I've done. So Judith, I don't know whether she'll take referrals directly from a wide range of people. That would only apply for people within BHRUT.
Yeah, that was what I mean. I said if we have BHRUT new to the trust that might not know that needs to do an internal referral. That was the purpose. I was asking if you can put it on the chat box for just BHRUT staff who wants to contact their colleagues.
What I can do is I can ask Michelle Salter actually to share that out with the team so they know without
okay, great.
The whole MSK team. So
that would be lovely. Thank you.
Be able to share that. So the other thing I suppose is to pick up on referral, because obviously that's okay for people that are internal with BHR. But obviously those that don't quite fit into the BPPV, which I know some of you will be aware of, obviously ENT is the other sort of source of referral for those that don't quite fit into the BPPV, isn't that right, Sabina?
Yeah.
Yeah, sort of the other groups of patients usually get assessed.
Any other questions? No, good. Yes, you can have a copy. Priya, yeah, you can have a copy of the presentation and the assessment guide.